Skull-based tumours are essentially tumours that grow in the brain, but really around the base of the brain. So you can split brain tumours into those that grow within the brain substance itself and those that grow around the brain. And skull-based tumours tend to be the ones that grow at the base of the brain and around the brain. And the reason why we consider them as a separate category is because, well, firstly, they cross boundaries between the brain and other parts of the body. So, for example, the nose or the ear. So often they're managed with between specialties like neurosurgery and also ear, nose, and throat surgery. And secondly, because there are lots of nerves that go to your special senses, like your eyes or your nose, your ears, and also blood vessels that are mixed in with these tumours. So they often require quite specific management because of that. Well, the majority of skull-based tumours are benign, but the reason that they are important is because they grow slowly, but they push those critical nerves and blood vessels out of the way and cause symptoms as a result. The cause is usually not known. So in medicine, we say that they're idiopathic. And for whatever reason, certain patients suffer from them, but we usually don't know why. There are certain genetic conditions that can be associated with skull-based tumours, like something called neurofibromatosis, which can be associated with meningiomas or vestibular schwannomas. But the majority of these tumours, they appear with age, and we don't really know why certain people end up getting them. Yes, I think, for example, the vestibular schwannoma is a very common skull-based tumour that I deal with on a regular basis. And the key sign with a vestibular schwannoma is unilateral hearing loss, which usually is unusual because it presents on one side, and also is associated with ringing in the ears and sometimes other symptoms like balance problems. So a simple hearing test will pick that up. And the majority of those tumours come via otologists and audiologists who have identified the tumour from hearing tests and then an MRI scan. Any symptom, it's not usually vague symptoms that that are associated with these tumours. Usually it's something quite specific because a specific nerve is compressed. So, as I say, hearing loss, for example, or you might find double vision or a drooping of the face or a drooping of the eyelid. It's often something quite specific that you might notice that would then stimulate an MRI scan. So most doctors or general practitioners would pick up on those specific signs. Yes, there are many different kinds of skull-based tumour. The most common two categories are something called meningiomas and something called the vestibular schwannomas I've talked about. The meningiomas, they grow on the meninges of the brain, which is the covering of the brain, but they particularly happen to occur around the base of the skull because there's quite a lot of meningeal tissue in that area, and because they cause symptoms quite early because of the nerves and the blood vessels in that area. The behavior of a meningioma is quite typical. In some ways, it's like a wart on your skin, but it's growing inside the cranial cavity. So because it's persistently growing, eventually it starts to cause symptoms and need treatment. But the growth is very slow. It's usually about 1 to 2 millimeters a year. But as they grow slowly, they can get to quite big sizes, and then they do really need intervention to stop them growing any further. The vestibular schwannoma, it's called that because it grows on the hearing and balance nerves specifically. So that tumor actually grows in the same region pretty consistently, but they are also quite common. And again, those tumors grow about 1 to 2 millimeters a year, classically, and the treatment options are also quite similar. So it's usually either monitoring or surgery or some sort of radiation treatment. I mean, there are a complex of other skull-based tumors, so it's not just those two categories, but those would be two of the most common. Well, yes. So, as I say, there's the three main options for treatment. And the first thing that we always do for these tumours is a repeat MRI scan, usually, unless it's extremely large or very symptomatic. Ordinarily, we would like to get an idea of the behaviour of the tumour first of all, and you will find actually a proportion of these tumours do not grow at all. So you can do an MRI scan at 6 months, and if there's no growth at all, you might do an MRI scan at 1 year and then monitor the tumour, and you may never require any treatment for it, which is the best scenario. You may find that the tumour is growing slowly and is small, and there is a particular treatment we have called stereotactic radiosurgery. One kind of stereotactic radiosurgery that we will do at Queen Square is called gamma knife radiosurgery, and that's a very focused form of radiation treatment which is given over the course of 1 day. So it's done as a day case, and it requires a frame to be fitted onto the skull under local anesthetic, and that means that we can focus the radiation very specifically at the tumour and avoid radiation going to the rest of the brain, particularly in these sort of sensitive locations where the skull-based tumours grow. And that's extremely effective, but doesn't remove the tumour, it controls the growth. So that's good for the small tumours that you don't want to get any bigger. But as I say, if you've got a large tumour and that's compressing structures, giving significant symptoms, or is at risk if there was further swelling, for example, then you are really talking about surgery. So I would estimate maybe 10 or 20% of the tumours will end up having an operation to remove them. And typically speaking, we aim to do the maximum safe resection that we can do. So often with skull-based tumours, you can't necessarily remove 100% of the tumour tissue because it's so applied to these critical nerves and blood vessels that you might cause a stroke, or you might cause a permanent injury to, for example, the nerve that gives you movement to your face. So we often will aim to do what's called a maximum safe debulking and take out maybe 80 or 90% of the tumour, relieve the pressure on the surrounding brain structures, and then monitor the residual. And if the residual does grow, then that may be treated with, for example, gamma knife radiosurgery afterwards. In terms of how we remove the tumours, there are lots of different methods of removal of tumour depending on where it is. So often these tumours grow in and around the brainstem, and you have to pick the appropriate approach depending on exactly where it is. And that might be through the side of the skull here, it might be from behind, it might be through the ear structures with ENT surgeons, for example. Also, skull-based tumours are removed up the nose if they're quite far forwards. So there's lots of different ways to remove them, and you really need the right set of expertise and the multidisciplinary team to assess each tumour on its location and size and the patient to decide exactly what is best, really.